Thank you very much. And I'm actually really sorry to interrupt the lunch. I think that actually what's happening over lunch and the conversations and it is probably even more important than what I'm about to tell you. But thank you very much for coming in. So I'll tell you a couple related stories in the context of germline susceptibility, in the context of biallelic mismatch repair, and also try and relate that to Li-Fraumeni syndrome and some projects that are undergoing and things that we're planning on doing. So I'll just set the landscape a little bit over here if you don't mind. So this is a cartoon representation of a single cell. It's obviously an idealized version of what happens in cancer. But what you can see is that from the fertilized egg through gestation up to early adulthood, that mutations are acquired. Somatic mutations are acquired throughout the life history of the individual. And whether these are passenger mutations that are just kind of along for the ride, they're not functionally important, or they're real driver mutations in key tumor suppressors or key oncogenes, they leave a certain mark on the cancer genome. And my lab is interested in using whole genome sequencing as a comprehensive and powerful tool for figuring out when those particular events arose. And I'll give you some tangible examples of where that's been useful. But the point is that all of these mutations leave a mark on the genome, and they become a powerful tool for molecular archaeology. So we were also asking ourselves if this gradual model, this cartoon figure, is really true for the evolution of most cancers. Or in the context, for example, of LFS or other germline susceptibility tumors, whether there's a different model of evolution, and my lab's really keen on exploring that in greater detail. And lastly, a question that has been with us for a few years is how does an early mutation, especially one that arose in the germline, shape the course of the somatic genome? Does it broaden the landscape and say, now you can have multiple different pathways that are disrupted, or does it narrow the focus of the tumor to try and knock out one specific pathway that is already mutated? So I'll tell you a story in some recently published work in the context of another susceptibility to cancer called biallelic mismatch repair deficiency. So in this case, you have two mutations, usually coming from one from each parent, in one of four of these critical DNA repair genes, PMS2, MSH6, MLH1, MSH2, with PMS2 being a little bit more frequent than the others. And you may be familiar with Lynch syndrome, which involves one mutation in these genes. CMMRD involves two. The spectrum of tumors is a little bit different. You have brain tumors, gastrointestinal cancers, lymphomas, and an extremely early age of onset. Importantly, before we began to look at the tumor genome, there was virtually nothing known about the molecular genetics of the syndrome besides what I'm showing you over here in terms of the constitutional mismatch repair, but nothing known in terms of the somatic landscape of whether they are different in any way somatically. And to make a lot of work, to summarize it very quickly, what we found early on is when you compare the cancer genomes from these patients who have an underlying 2 hits in DNA repair, they are universally ultra-hypermutated. So that means that as compared to your typical sporadic childhood brain tumor or childhood cancers, or in fact, if you look at the vast array of adult cancers, these ones really stick out like a sore thumb as being ultra-hypermutated universally. So this is one mutation per 3 kilobases of DNA. Every single gene is disrupted in one way or another, usually hit multiple different times. How does this happen? Well, it turns out that there's a critical secondary gene that arises in the context of CMMRD. So that is polymerase epsilon or polymerase delta are mutated usually by missense changes in the exonuclease domain, giving you what we call complete replication repair deficiency. So it's the combination of these two things which gives you ultramutation. And this is where I think it's important for the context of discussion of LFS. We use this concept of mutational signatures to look for details, to look for patterns in these mutations. Really, when we started, we thought to ourselves, you have this core pathway that's disrupted. It could be just complete randomness. It could have just total disruption across the cancer genome. But we applied this concept, and this thing is a mathematical way of summarizing all the mutations wherever they land across the cancer genome, whether they're in p53, whether in MSH2, whether they're in the middle of an intronic space that does absolutely nothing. Those mutations arise with a specific nucleotide context. So you may have heard, for example, that the tobacco smoke has a specific mutagen. In fact, it has dozens of mutagens that leave a signature on lung cancers. The same thing is true for UV light and skin cancers. But in many childhood cancers, the signatures are not known. This is especially true for relapsed childhood cancers, and this is all the more so for those that arise in the context of a susceptibility to cancer. So we applied this concept of mutational signatures. I wouldn't have given you that long introduction if it didn't have a positive result. And what you can see here are these fingerprints for each cancer genome that are strikingly similar to one another. I should mention that one of them was sequenced in England while I was a postdoc, another one was sequenced in Toronto, different labs handling in different ways. They all have this very exquisite signature, which we were able to characterize as being the POL-E plus MMR signature. And it arises in this particular context. More recently, we collaborated with a private company that has sequenced using panel sequencing, so that is they focused on 200 genes, a large number of cancers, vast majority of which are adult cancers, so they've done about 78,000 cancers. And we asked the question of whether we could, we asked if we could dig deeper into their data set to look for the causes of hypermutation, to see what proportion of them are due to extrinsic factors, intrinsic factors, and then essentially to pick up where we had left off. So first off, we were able to look at 2,885 hypermutant childhood cancers, which is by far the largest cohort that's been examined in childhood cancer, and especially so in the context of hypermutation, which is, and I should remind you that childhood cancer is thought as a quiet cancer genome. That is true. Generally, what you see is that the mutation burden is pretty low for most childhood cancers, but when you get to here, you see that there's about 5% of tumors that are hypermutated. This includes things, not just the brain tumors that I told you about already, but also sarcomas, neuroblastomas, and others, and these might be vulnerable to immune checkpoint inhibitor therapies. And importantly, when you look at the cutoff of greater than 100, which is the ultramutation category that I showed you before, this is universally replication repair deficient, whereas in this section it's simply enriched. So what we can say is in childhood cancer, hypermutation is mostly due to replication repair defects, but there's probably something else underneath that as well. And we're currently digging into it in greater detail. In adult cancers, I'll fly through. It's not as relevant to this talk, but there's also a striking long tail of adult cancers that are hypermutated across the entire cohort. And what we all struggle with in this room are these variants of unknown significance. And where you have a variant in p53 or elsewhere, and there isn't enough functional evidence to allow us to place it one way or another, whether that's a germline variant or a somatically acquired one. So Brittany came up with a really clever idea where she said, let's use the tumors themselves, their mutation burden, and their signatures as a readout for functional impairment of POL-E and POL-D. Let's let the tumor tell us as a functional assay, an in vivo human reporter, if you will, whether those mutations are important in that particular context. So here's a tangible example of one actual tumor that has 3 possible driver mutations in POL-E. And when you compare every single one of those drivers to all the cancers, 1,500 tumors that were hypermutated in the Foundation Medicine cohort, you see that only one of them stands up to the test of being a true driver. And using this methodology, Brittany was able to rediscover the full landscape of POL-E and POL-D drivers just from first principles, just from looking at the cancers and letting them tell us what was important or not. And there's a lot of the exonuclease domain mutations. And what's also important is that she was able to discover 11 new residues on top of those that had already been found. And I think even more critically is to be able to discount things that are probably mere passengers, things that have high recurrence. So statistically might look like drivers, but in fact are just really along for the ride and not associated with hypermutation in any way. And then Nick, who's here and who's involved in both aspects of this presentation, decided that he was going to perform an unsupervised analysis again, also looking at the trinucleotides of the cancers. And instead of looking at them in the context of whether they're microsatellite stable or unstable, or whether they come from the prostate or breast, allow them to self-report. And what Nick found is that there are 8 major clusters of hypermutant cancers. And these are really anchored by the major mutagens and the tumor types that you would expect to see, for the most part. So, for example, here's this big cluster of UV light-associated cancers. Many of those are skin cancers. They're in cluster number 6. There's these temozolomide-associated brain cancers in cluster number 5. But what we discovered is that there's actually a much broader activity of these major mutagens with the clusters that are found as well. So in fact, in the UV light-associated cluster, there's a number of sarcomas that we didn't expect to find there as well. And importantly, the mutational signature, again in this unsupervised way, became also a way of checking the diagnostic and the pathology as well. So I could mention one small vignette that in about a third of the most hypermutated lung cancers, we're able to re-diagnose them as actual skin cancers based on the percentage of the signature that they found that they had within them. But our interest was in replication repair deficiency, so we honed in on 3 clusters that you can see over here. And you can see that the cluster number 2 is this broad cluster, lots of cancers in it, mostly made up of colorectal cancers. These are the MSI colorectal cancers that many people are familiar with. They're polymerase epsilon wild type, mostly happen in adults. I should mention there's again a long tail. Whereas clusters number 1 and 3, much smaller, are slightly hypermutated as compared to the other ones. All of these are hypermutated, but just degrees of hypermutation at this point. Both POL-E mutated, whereas cluster number 1 was almost primarily involving kids or young adults. So what we can say is that we've discovered 3 major subtypes of MMR based only on the signatures, and these differ in their microsatellite instability status, whether they're driven by a polymerase epsilon secondary mutation, and the age of onset of the tumors, and of course there are different tumor spectrums that go along with each one. And what Nick then wanted to do was to see whether he could understand the timing of the mutations and the rate at which they arose. So he took cancers that we had sequenced internally at SickKids, for which we knew the exact major sort of life history events, if you will. So primary MMR, secondary POL-E. Primary POL-E, secondary MMR, primary MMR, and then TMZ-treated brain tumors. And then what Nick did was he went fishing in the larger data set to try and match them up to the clusters that I'd already defined. And sure enough, cluster number 1 matches the CMMRD situation that I told you about before. So it's not just about the pathways that are disrupted in the cancers that defines the mutational signatures, it's about the order in which those are disrupted. That gives you a specific spectrum and a proportion that allows you to go back in time and infer something that went wrong. And I'll just to make the point again, if you look at cluster number 1, those inherited CMMRD cases, what you see is they have a high mutation burden, and also leaving the gate, this is sort of a way of looking at time. And as they acquire their secondary POL-E change, they just become exponential, whereas clusters 2 and 3 are pretty similar until POL-E is mutated, and then cluster number 3 takes off. And this has important implications for the overall survival of the patients, with those with the most explosive cancers doing the worst. And importantly, for our ongoing efforts in LFS, what we've been able to do in CMMRD situation is looking at the cancer. So in this case, looking at 80,000 tumors, we can infer the presence of an underlying germline condition based only on the combination of a high mutation burden, a true driver that's detected in the way that I showed you before, and then a particular early signature. And what we did was we then said, okay, well, here's a flag for all these cases where we suspect that there's a germline syndrome happening. We contacted the physician, recommended a lab that could do CAP-CLIA-based germline diagnostic testing for PMS2 and the other genes. And in the cases where they were positive, initiated tumor surveillance. And in the case where they had ongoing cancers that were eligible for immune checkpoint inhibition, went forward with that novel therapeutic avenue. And this is now a little bit out of date, but there are about 30 patients that have gone through this scheme where, looking at the tumor, we do what Uri refers to as reverse genetics to try and find that underlying germline MMR condition, and in 100% of them, they were found to be positive, confirming what we had found initially. Here's an example of a young boy whose brain tumor was discovered by surveillance and then resected, and two early examples of patients who went through immune checkpoint inhibition strategy with nivolumab as part of a off-trial study which is ongoing. So here's some data that's basically just cooking, and then you can talk to Nick if you want, if you'd like some details, but I'd like to share some of the data as it's coming off the machines right now. So we're also asking ourselves some of the very same questions using some of the same technologies in the context of LFS. So are these cancers different? Do they evolve differently? Are there mutational signatures? Are there key secondary events that arise in the context of LFS that don't arise in the context of a sporadic tumor of the same histotype? So, those are big questions. I don't have any of the answers yet, but we're working on it. So our strategy in Li-Fraumeni syndrome is to do what's called multi-site sequencing, which is essentially to take these small biopsies, and which are sometimes a couple millimeters apart from each other, to cut them in a very fine way. We've optimized the protocol. We extract DNA, extract RNA, and we do whole genome sequencing as opposed to doing the targeted panel sequencing, because what we know about p53 is we expect there to be massive numbers of rearrangements, things like chromothripsis, and we want to make sure that we capture that as well. And expand our notion of mutational signatures to include those kinds of rearrangements that you see in a p53-driven cancer. And I should say everything that I'm showing over here has already gone through whole genome sequencing, and it's making its way through analysis. The people I mentioned already are Nick, and also Mehdi, who's especially interested in the mutational signatures angle and developing that a little bit further, looking at rearrangements, as I mentioned, and also looking at other forms of mutations that might have patterns to them. And already, using this multi-site sequencing approach, we can begin to time the origin of secondary mutations in LFS. We can begin to look for convergent evolution, where in some cases you see that there's a secondary mutation that's acquired in two branches of the phylogenetic tree, and we can begin to measure the lengths of these branches to see how many subclones arise in an LFS cancer. And strikingly, when you look at the copy number, each of these, this is showing you the total copy number depth in the two, the A and B, the sort of maternal and paternal alleles, for a tumor that's been zoomed up quite a bit. This is just to show you what 1 millimeter is. That there is massive heterogeneity between these sites that are really very close to each other, where you hear there's two whole chromosome losses that are absent from this section, which is 1 millimeter away, and also absent from this other section, which is 2 millimeters away. There's something which is gained over here, which is found, I think, subclonally in its neighbor, and then absent entirely from this sample. So this data is ongoing, and stay tuned. And the next thing which I'll tell you about is our efforts to implement a precision medicine program to sort of take a lot of this data. It's wonderful to be able to learn something about cancers that have been banked, and there's enormous value to having these banked samples so that we can microdissect them and perform whole genome sequencing, which is the most exhaustive way of characterizing their mutational landscapes. But we also, in parallel, have initiated a program to look at patients who are coming into the hospital with hard-to-treat relapse tumors and to sequence their genomes in as close to real time as we can. And the reason we do that is because not only do we want to target it using targeted agents, but we know that in this genome, which has thousands of mutations, are a number of clinically relevant mutations, not just to target, but also to substratify the tumors, to help with diagnosis. Many childhood cancers are diagnosed on the basis of a translocation, for example. And with that in mind, we initiated a prospective sequencing program called KICS. And I won't take you through our hypothesis statement, but essentially to realize that this is going to be standard of care quite soon. So we should really get on with it to try and kick the tires and see what needs to be done to make it operational in our hospital, and to think about how we can not just think, but actually scale it nationally across the country. This is a collaboration, importantly, between the diagnostic lab, and Caroline Ryan is here, who does a lot of the extractions and managing the samples that come through, these precious small specimens, and the TCAG and HEMONC, led by Anita, David, and I. And what we do is we sequence both the DNA using whole genome sequencing. We also do targeted panel sequencing, and we and look for variants that meet the categories that I've showed you before. And just to fly through a little bit of the preliminary results. Again, this is data that's ongoing, but you can see if you categorize the variants that we find by either panel sequencing, RNA sequencing, or whole genome sequencing, and various classes of clinical utility, we've been struck by how many important mutations we are finding. So we have every single week a tumor mutation board meeting where we get together, multidisciplinary, and talk about the variants. And thus far, of the 200 patients that we've looked at, there are about half of them that have at least one actionable finding on NGS analysis. And what we hope to do is expand this program for any LFS family. So this is also something that is under development, but it would potentially offer new personalized therapy options for LFS patients, not necessarily on the basis of the p53 dysfunction, but of the rest of the genome, which can also be potentially offer new therapeutic avenues. To make this, to scale up this program so that we could have broad availability nationally, and that already has happened in terms of something called Profile, which I'm happy to talk to you about separately, but also to do it internationally. And I just mentioned again that this is under development, and the preliminary data that exists so far. So, for example, of the 2 patients that have come through KICS of the 200 that were LFS. First is a 16-year-old female with an aggressive brain tumor. It's a 337C mutation, found by cancer panel to be, to our surprise, hypermutant. So 27 mutations per megabase. I can't remember what the signature is offhand, but I think there was an interesting signature as well. By RNA-seq, had a MET in-frame fusion with the kinase domain intact, and would have therefore been eligible for multiple different potential therapies, including the nivolumab therapy that I know that is open currently at SickKids, and this would have been potentially targetable by crizotinib. Unfortunately, passed away prior to the return of the results. Second LFS patient sequence thus far is a 14-year-old boy, also with a similar brain tumor, this time a 282 mutation, who was found to have a BRAF mutation and was therefore enrolled on a dabrafenib trial. And with that, I'll thank everyone. I'm happy to take a few questions. Thank you.